And all right, and so Andrea will introduce our speakers in just a moment, but as usual, as the talk is going on, please put your questions into the Q&A button at the bottom of your screen, and we will read those questions off at the end of the talk. Andrea, do you want to go ahead and introduce our speakers?
Good morning or afternoon, depending on where you are. I'm so thrilled to introduce Dr. Tessa Matson and Joe Glass. So Tessa is a collaborative scientist at Kaiser Permanente, Washington Health Research Institute, working on research addiction, addressing addiction health services within primary care and in patient-centered ways to reduce disparities. And applying implementation science expertise to NIDA-funded trials to improve the provision of care for individuals in these settings. And then Joe is associate investigator at Kaiser Permanente, also the Washington Health Research Institute, and affiliated associate professor at University of Washington, and also studies how to bring effective digital and maybe non-digital too, Joe, but no more of the digital stuff to within primary care and other healthcare settings. How do we implement those tools? Turn it over to you. Thank you.
Great, thanks so much, Andrea. Okay, so let's share my screen. How does that look?
Yes, great.
Perfect. Well, thank you for joining us today. We are very pleased to be presenting on a proposed framework for designing trials, evaluating the effectiveness and implementation of digital behavioral health interventions. So we'll start by presenting the motivation and phases of this framework, and then we'll walk you through an example. And we should have plenty of time at the end for a robust discussion. So we'd really love input you have and questions, comments that come up. I'd like to acknowledge and thank our collaborators who were instrumental in helping design this framework. They are pictured here. And this work was supported by NIAAA. Views are our own and do not necessarily represent the official views of the National Institutes of Health. We do want to disclose that Kaiser Permanente Washington received a digital therapeutic prescription at no cost from Pear Therapeutics during a quality improvement pilot study facilitated by Dr. Joe Glass. So when I talk about digital interventions, I'm referring to software such as websites or mobile apps used by patients to improve health outcomes. While this framework we propose is designed to be applied flexibly to any behavioral health condition that can be treated with a digital intervention, Joe and I are addiction health services researchers, and so the examples we provide today will be focused on digital interventions for substance use and substance use disorders. In the field of substance use, digital interventions may be used for screening, brief intervention, or to deliver evidence-based psychosocial treatment. So these are things like cognitive behavioral therapy, contingency management, and motivational enhancement therapy. They also have the potential to address barriers and bottlenecks to substance use treatment, such as stigma or limited capacity. There's evidence of efficacy to indicate that digital interventions improve treatment outcomes, but limited evidence of effectiveness when used by clinicians and patients in real-world conditions. And when I say real-world conditions, I'm emphasizing the use and delivery of digital interventions by staff who work in a service system, which is very different from a situation in which researchers maybe take on the duties of staff to facilitate app delivery. So mixed findings in the literature may be related to challenges implementing digital interventions in healthcare. Effectiveness of digital interventions in real-world settings may therefore depend on their implementation. We hypothesize that implementation failures, in fact, may explain the lack of effectiveness seen in some studies.
So the question is, so why is it so hard to implement digital interventions in real-world settings? We know that they have unique implementation considerations, and they often don't fit perfectly into traditional care pathways. So some healthcare settings may have a really robust technology infrastructure to support digital interventions. You can imagine a clinic that has Wi-Fi support that can be used by patients while they're in clinical offices. Some health systems have patient portals where patients can download health and wellness apps. But this type of infrastructure could be rare, limited to well-resourced healthcare systems. And other challenges include that digital interventions themselves are constantly updated. They're rapidly versioned, new versions coming out all the time. And this new versioning could outpace the rate at which smartphone apps, or the new versioning could outpace the rate at which healthcare systems can catch up to these smartphone apps to change their workflows to accommodate any changes in the technology. Additionally, patients themselves may have varying levels of digital literacy, and healthcare providers may need to teach patients how to install, set up, and use digital interventions on their smartphone. And also, depending on the digital interventions capabilities, clinicians could be required to interact with the app vendor's software, which sometimes sits outside of the institution's electronic health records, actually, which usually sits outside of the institution's electronic health records. So it requires clinicians to use not just a separate system, but a whole new system. So we think that implementation efforts will also need to consider not just how to get clinicians to start using them, but also how clinicians will monitor patients' app use and follow up with them over time. So for instance, some apps allow providers to see patient progress through a shared dashboard, a web-based dashboard. Health system might need to make decisions about will they do outreach to patients who have started apps to help promote their engagement over time. And in general, they may need to just redesign their workflows, to change the way that patient care is conducted, just to support the use of apps. So a lot of these activities to support digital interventions, as I mentioned, often fall outside of the scope of normal clinical duties. And so what the challenge is just identifying how to fit these duties into clinical workflows. This has been a major pain point in studies conducted under naturalistic conditions. And so this is something that we're particularly interested in, and we know many of you are as well. So let's see. I'm going to wait for the next slide to pop up. Here it is. Okay. So recognizing the need to understand how to support digital interventions in clinical settings, there's been a surge of studies yielding important information about ways in which healthcare systems and other service organizations could deliver digital interventions in clinical care. So here's some potential solutions. Clinical workflow studies have engaged patients, clinicians, and clinical leaders to gain insights into how to best integrate digital interventions into existing clinical workflows. A lot of these studies have applied qualitative research methods, user-centered design approaches, as well, to understand ways that clinicians can introduce and offer digital interventions to patients. They've also helped to understand how staff or software vendors could assist patients in setting up apps and provide patients with technical support, and how clinicians could provide longitudinal follow-up and monitoring of patients who are already engaged in the use of digital interventions. So those are the clinical workflow studies, but other studies have focused on changing staffing models, like how do you staff your clinics in order to help patients benefit from digital interventions. Some of these studies have explored whether special responsibilities required of clinicians when using digital interventions. Could these new special responsibilities be offloaded to specialized staff who are hired into the clinical environment for this express purpose to support a digital intervention delivery? Some examples in the literature include the hiring of clinical technology specialists, using peer specialists, or health coaches. Another set of studies on the delivery of digital interventions in clinical care have explored how to create what's called digital clinics, where interventions are incorporated into nearly every aspect of care for every patient and clinician. So in other words, the use of digital interventions as part of patient care is just considered, the default thing to do. Something like this could be an appealing option for well-resourced health systems, as well as health systems who aspire to be leaders in digital innovation. Okay, so while those solutions that I just talked about have explored new ways to deliver digital interventions at the point of care, another research area focuses on how to improve the process of implementation. So one study, a great example of that, study by Dr. Andrea Graham here, who just introduced us today. Andrea and her colleagues described ways that implementation strategies could be used to address barriers and facilitators at every stage of implementation, from adoption through sustainment. For instance, they described how it could be beneficial to conduct rigorous needs assessments before implementation, to create learning collaboratives for clinicians so they can share resources with one another as they learn how to use digital interventions, and to continuously optimize implementation plans, and to continuously optimize the digital intervention itself over time to ensure long-term fit within the care setting and within the targeted population. The implementation strategies, like the ones discussed in Dr. Graham's study, as well as the approaches for delivering digital interventions in clinical care that I talked about previously, these are all very promising, and practitioners should consider using them when designing their own implementation of apps. But we also argue that these approaches should be studied in randomized implementation trials to try to figure out which one of these approaches work best, what implementation strategies are the most beneficial, and so on. And recently, protocol papers for 2 randomized control trials conducted by the authors of this framework have described their experiments that are testing new ways of either delivering digital interventions, new ways of implementing digital interventions, or both. We would like to encourage more trials in these areas because the field needs to optimize approaches for delivering digital interventions in routine care. And we'd like to see more studies compare the impact of different implementation strategies on the success of implementing digital therapeutics. And we also think it's surprising that there aren't too many studies out there today because it's pretty clear that the major stumbling blocks for digital interventions to date have involved issues related to how to deliver them in a real world healthcare setting. And how to implement them and encourage implementation so clinicians use them routinely. So again, we argue that more RCTs are needed in this area, or randomized control trials are needed in this area. And we're here today to propose a framework that will help researchers design trials to answer important research questions that will help advance science around implementing digital interventions into routine practice. So to summarize our motivation for proposing this framework, given the unique implementation challenges of digital interventions, more guidance is needed on the design of trials that overcome these new challenges. We specifically think that more studies should seek to answer questions about how best to deliver digital interventions. Specifically, we need to test approaches for delivering digital interventions under real-world conditions. In other words, research studies need to be designed to answer the question of what is the best approach for offering and supporting the use of digital interventions in this service setting. And finally, we acknowledge that many issues affecting the delivery of digital interventions may be highly tied to context in which they are delivered. So in other words, the unique intricacies of the healthcare system or service setting. So there may be some concern that knowledge gained from one trial may not generalize well to other digital interventions that are selected for implementation or to other patient populations or healthcare settings. So therefore, we think it's critical for researchers to try to harmonize the ways they specify what they're doing, the way they communicate, what their implementation approach, as well as their study design approach. And that'll help facilitate replication and unpacking what's called the black box of implementation in terms of we did something that works, and you know what specifically what about what we did was helpful. So so here we're so Tessa will take over here and she'll tell us about the framework that we're proposing for designing trials that seek to address questions about the implementation and effectiveness of digital interventions in real world care. A couple more slides by me first. I wanted to just tell you, like, how did we develop this framework? It really were, you know, quote, standing on the shoulders of other giants. So we drew from literature on trial design in general, like outside of the digital interventions literature, as well as expert perspectives. The team that Tessa showed earlier today, the pictures of folks, there's a lot of aggregate experience there in conducting studies of digital interventions, as well as lessons learned that are reported in the literature. And as we describe this framework to help make some of the concepts more concrete, we're going to discuss how it applies to, and how the framework applies to a randomized control trial that's currently testing approaches for implementing digital therapeutics for substance use disorder in a real world healthcare setting. And this randomized control trial is called the DIGITS trial. So I'll tell you a little bit about the DIGITS trial for some context. So this trial is comparing different approaches for delivering digital therapeutics to patients with substance use disorder who are seen in primary care clinics. It's also comparing implementation strategies for improving implementation and sustainment. So everything that we mention about this trial has been published in the articles shown on the slide here. And there's a QR code, you could pull it up if you like. In this study, the digital interventions that are being implemented and studied include 2 FDA authorized digital therapeutics, meaning that they have been authorized by the US Food and Drug Administration for the treatment of substance use disorder. These are called Reset and Reset-O. They're app-based treatments that are designed to be used under the guidance of a clinician. And Reset is used for the treatment of substance use disorder. So that's one app. And the other app, Reset-O, has specific indications for the treatment of opioid use disorder. And in this trial, a total of 22 primary care clinics are implementing these digital therapeutics using a standard process that the health system had previously used in the past. And so we call that standard implementation. But in the RCT, what we're doing is we vary the type of support that we provide to each primary care clinic. Specifically, we're testing whether an implementation strategy called practice facilitation increases the proportion of patients in a clinic who are prescribed the digital interventions. We're also testing whether supplying primary care clinics with a health coach who assists patients in using the app improves fidelity to use of the app, which is defined as the use of the app to clinical recommendations, or using at least 4 modules of the app per week. There's also a cost effectiveness component to the study, and it has a 1-year implementation period. And so we studied the implementation for 1 year, and then it's followed by a 1-year sustainment period in which we're slowly removing the implementation resources added by the research team, and we're continuing to study the health system's ongoing use of the digital intervention. Okay, so now I will actually hand it off to Tessa.
Thanks, Joe. Okay, so returning to the framework for designing trials of digital interventions, we propose 3 major phases. First, framing the research question. Second, delineating the components being studied, which I'll define in a second. And third, specifying core features of the trial design. While we start with the research question, this process is not strictly linear. Specifying core features of the trial design may require researchers to revisit the research question. At each phase, we suggest the researcher consider 3 components specific to the effectiveness and implementation of digital interventions. So these include the digital interventions themselves, so the apps that patients use, the clinical support services deemed necessary to deliver the digital intervention. So this has also sometimes been called the human touch. And then finally, the implementation strategies. And I'll provide an example from digits for each of these components as we move through the framework. Okay, so phase 1. All aspects of trial design should follow the research question. Therefore, in phase 1 is to identify a research question that is timely, relevant to stakeholders, and worthy of an experimental design. We propose that researchers frame the research question in terms of the components to be tested. So, for example, research questions that focus on features of the digital intervention itself might ask whether the digital intervention works in a particular population or setting, how much patients will benefit, and if there are multiple options, which digital intervention to use. These questions are of particular interest to stakeholders who want to know whether to invest or in which product to invest. In the digits trial, this was a secondary focus, given that trials had previously been conducted in specialty care settings, but not in primary care. Research questions may alternatively focus on the level or type of clinical support services, again, what we might think of as the human touch. And so what approaches or clinical workflows for offering digital interventions are needed to support their delivery in real-world settings? These questions are of particular interest to clinical stakeholders who need to know how to reorganize staffing resources, whether they need to hire new staff or contract out to a third party to support the digital intervention. So the digits trial explicitly tested whether a dedicated health coach who supported patients in setup and patient engagement with the digital intervention improved its delivery. So in the trial, this was framed as an implementation strategy, but the health coach was a medical assistant who was part of the primary care team and may be more in line with how we define clinical support services. Finally, there are research questions that focus on implementation strategies. So these might ask about the strategies needed to promote adoption, implementation, sustainment of a digital intervention in a real-world setting. And so these questions are of particular interest to stakeholders who already have buy-in, but are not sure how to maximize uptake of the digital intervention in their setting. So digits is a clear test of an implementation strategy. In the digits trial, it was practice facilitation. Okay, so if you're an implementation scientist, you're probably used to thinking about interventions versus strategies. This framework recommends a third thing, which is clinical support services. And as we've already begun to see, the clinical support services can potentially overlap with the digital interventions themselves or with the implementation strategies. However, we also believe they're a distinct component critical to effectiveness and implementation and worthy of study in their own right. So in the digits trial, the clinical support service we're using as an example is a centralized clinician, a medical assistant, which we call a health coach. However, other clinical support services might include changes to the clinical workflow, such as placing an order for the app, initiating a warm handoff to an integrated mental health specialist who's trained in providing behavioral health care. Or a clinical support service might be a dedicated digital intervention clinic that coordinates all digital interventions for a specific health condition. Or it might be peer specialists or other clinical specialist staff. We can conceptualize clinical support services as a way of organizing care. So care management or the collaborative care model similarly are approaches to organize and deliver several interventions that have an evidence base. But in this case, we're referring to clinical approaches for organizing and delivering care for digital interventions. Another way of distinguishing clinical support services from implementation strategies, specifically, is to consider the impact of their removal. So as an example, practice facilitation, an implementation strategy, may be available for a finite period to increase adoption, but health coaching might be a critical part of delivering the intervention that can't go away. Phase 2 is to delineate the components under study. So given this potential overlap between the 3 components, the goal of this phase is to bring clarity to the boundaries of each component for your study. Clear and accurate delineation of trial components is critical to health system stakeholders who must understand program content and requirements in order to make endorsement, funding, and implementation decisions. So we recommend delineating the components under study based on 4 dimensions: actors, activities, action targets, and proximal outcomes, as advocated by Proctor and colleagues. So here's an example. We'll delineate the components studied by the DIGITS trial. So starting with the digital intervention itself. In the DIGITS trial, there were 2 smartphone apps for substance use and opioid use disorder called Reset and Reset-O respectively. So the actors were patients with substance use or opioid use disorder. The activities were time using the app to engage in community reinforcement, contingency management, and fluency training. And then the targets of those actions are to explore healthier ways to meet a need, and sense adherence and abstinence, and reinforce concept mastery. Proximal outcomes relevant to the digital intervention include substance use reductions and treatment engagement. So for the purposes of this example, we'll consider health coaching and the DIGITS trial to be a clinical support service. The actor in this case is a centralized medical assistant. The actor conducts phone outreach to patients and monitors and encourages engagement, encourages practice of skills, and facilitates follow-up with the care team. The targets of these actions are to activate patients and reduce the burden on clinicians, support patient skill development, and promote collaboration between patients and providers. Outcomes relevant to this particular clinical support service include fidelity to clinically recommended use of the app and feasibility. Health services or process of care outcomes may also be of interest to trials focused on clinical support services. And lastly, DIGITS sought to test an implementation strategy, practice facilitation. The actor is a practice facilitator who's external to the clinical care team. This actor provides education, audit and feedback, PDSA cycles, and engagement in the context of a supportive relationship, with the goal of creating clinic-wide demand, clarifying measurable goals to improve performance, reinforcing mastery of treatment concepts, and supporting local implementation efforts. Outcomes related to this implementation strategy included reach and adoption. So the details of phase 2 are trial specific and may look different for your study. The goal here is to clearly identify and delineate the digital intervention from the clinical support service from the implementation strategy. In phase 3, we specify core features of trial design. So these should be driven by the research question. Phase 1 helps the researcher articulate what they want to learn. Phase 2 helps the researcher gain clarity about the different components so that in phase 3, we can now isolate those components in an experiment. PICO is a widely known strategy for reframing research questions in a precise and testable manner. So PICO stands for population, intervention, comparator, and outcome. Some applications of PICO have been recommended, 2 additional dimensions, timing and setting, and this is helpful to capture intervention complexity. This detail can also be helpful to report for future studies wondering if results will generalize to other settings or populations. Okay, so the population is who the trial is targeting. What are the important characteristics of this population? In the DIGITS trial, there were 2 populations of interest: integrated mental health and primary care providers, as well as patients with a drug use disorder. The intervention is the experiment or thing to be tested. So we suggest considering each of the previously considered components that will be empirically tested. In the DIGITS trial, DIGITS tested 1 clinical support service, health coaching, and 1 implementation strategy, practice facilitation. They did not test the digital intervention itself. Okay, so for the comparator, the control or comparator must appropriately isolate the component under study. And so if you're wondering how to choose a comparator that isolates the studied component, there's a resource called the Pragmatic Model for Comparator Selection, which was proposed by Friedland and colleagues that can help researchers make this determination. So digits compare the intervention to standard implementation. So this included things, typical things health systems do to roll out new interventions, such as training, adding templates and tools to electronic health records, and providing performance feedback to health system leaders. It also provided clinicians with a manual of instructions on how to provide the digital intervention to patients and set steps for conducting appropriate follow-up. So by comparing practice facilitation to standard implementation, it answers the question of whether additional implementation support will enhance a clinic's ability to deliver the digital intervention. By comparing health coaching to standard implementation, it allows us to answer the question of whether clinicians embedded in the healthcare setting can facilitate the use of a digital intervention themselves, or might they require additional support from someone outside of the health team to improve patient engagement. So outcome. For the outcome, consider whether the goal is to improve clinical effectiveness, delivery of health services, or an implementation outcome. The DIGITS trial focused on 2 implementation outcomes, fidelity and reach. For timing, consider the period during which the trial will occur and the period of follow-up. While it may not be critical, it could be useful to note contextual factors related to timing, such as occurrence in the middle of a pandemic. So DIGITS had a 12-week intervention per patient and a 1-year active implementation period. And then finally, the setting can be useful to contextualize where the trial occurs. For example, was it in a specialty mental health, primary care, or a community-based clinic? DIGITS took place in an integrated healthcare setting where mental health clinicians were embedded into the primary care teams. So now we put it together to frame the research question in a testable manner. For health coaching, we might ask, in the context of an integrated healthcare setting, S for setting, do primary care clinics randomized to health coaching, I, the intervention, compared to standard implementation, C, the comparator, have a higher mean number of weeks in which patients with documented drug use disorder, P, the population, use reset and reset-O as recommended, O, the outcome, over the 12-week intervention, T for timing. Okay, and so then for practice facilitation, I'll go a bit faster. We might ask, in the context of an integrated healthcare setting, do primary care clinicians who care for patients with a drug use disorder in clinics randomized to practice facilitation compared to standard implementation prescribe reset and reset-O to a higher proportion of eligible patients with a documented drug use disorder during a 1-year active implementation period? So now we specify the trial design. Hybrid trials are especially useful in this framework because they allow you to answer questions related to implementation while also gathering information on effectiveness or vice versa. So on the spectrum from effectiveness only to implementation only, hybrid trials sit somewhere in the middle. They often have a primary focus that is studied with experimental methods and a secondary focus that may be studied observationally. They're well suited to studying digital interventions where the effectiveness data may be lacking or limited, but there's a political will to implement the intervention to fulfill a treatment need. To determine the type of hybrid design, consider the primary research question. Studies whose primary research question is about the effectiveness of a digital intervention are typically classified as a hybrid type 1. Studies with an equal focus on effectiveness and implementation are typically classified, as hybrid type 2. And studies whose primary research question is about implementation, but have a secondary focus on effectiveness are typically classified as hybrid type 3. In the DIGITS trial, the primary research question was focused on implementation with a secondary focus on effectiveness. So we considered it as a hybrid type 3. Given that we recommend a third thing, where do clinical support services fit in this framework? Studies whose primary research question is about the clinical support services could be a type 1, 2, or 3. We recommend, sorry, multiple screens open. We recommend selecting a design based on the main research question. So if your primary research question is whether clinical support services enhance effectiveness of an app, and there's a secondary focus on implementation, it's probably a type 1. These trials will often have a researcher delivering the support. If, on the other hand, the research question is regarding implementation of a clinical support strategy, how it improves delivery or use of an app when delivered by a clinician, the study may be classified as a hybrid type 3. We recognize there's substantial variation in how researchers use the hybrid design classification. So regardless of how you classify your trial, we recommend researchers clarify and report their rationale. Implications. So as demand rises for digital interventions to meet a treatment need, so too does the need for trial designs that consider the unique implementation challenges that digital interventions pose, in addition to the clinical effectiveness. Returning to our original motivation, which is listed on the left-hand side, we propose this framework to help researchers design, review, and execute trials of digital interventions by proposing a process and a lexicon to harmonize trials. The process of identifying and delineating trial components may also help decision makers understand how to apply findings in their own setting. The framework underscores the need for trials that examine the impact of clinical support services on the effectiveness and implementation of digital interventions, addressing an important gap in current research. And finally, this framework advocates for the use of hybrid trials of digital interventions to advance evidence to practice and increase the applicability in real-world settings. So I'd like to pause now for feedback. This is a working framework, and we welcome comments, questions, other ideas that you have. And I've also included our contact information on the slide if you'd like to keep this conversation going after the webinar. Thank you.
Thank you. That was fantastic. We had a few questions come through. And Joe, I saw you were able to respond to one of them, but it might be just good for the group to hear that one and then, your thoughts, and then to see the others. I can read them, but it seems like you then have good access, which is good.
Sure. So maybe I'll start with that first question, and then we could look at the other one. So the first one, which was answered in the chat, pretty cool chat function you got here. It was the question was by anonymous attendee, I guess is the way that Zoom is listing. The question was a really good one. How do you balance the time feasibility and implementation RCTs often take with rapid and quick updates and developments of digital health tools? So the way that I'm understanding the question is, as we mentioned, a lot of digital interventions are updated rapidly, and they may change over the course of a couple months, whereas randomized control trials, can take a year just for the fielding, and a couple of years for development and getting grant funding. Yeah, I mean, it's a great question. So I replied in that chat with a link to an article that's specifically about that topic, actually by David Moore and colleagues. And I think that one way to, another opinion about that is that you'd want to figure out what is the actual, what is the specific thing that you're testing in the RCT, and how much will you allow it to change. So in the in the implementation science world, there's a recognition that health systems constantly change, for instance. And so you may start a trial with a very good idea about exactly how you will deliver an implementation strategy, the timing of it, who you'll work with, what you'll do, and how. And it's really critical to make those plans up front. But as health systems change, you need to pivot. And so what's really critical is documenting how you pivoted, and why, who are the decision makers, who said, yeah, we need to change our plans. And so that example is talking about implementation strategies and adapting to how health systems change. But you could also think about how that same thing applies to digital interventions. You know, as digital interventions change, it may change like what you sought out to test, right? If you're doing an effectiveness trial of a digital intervention and it changes midpoint in your trial, you may think that's a bad thing, especially, you know, if you're trained from a kind of more traditional trialist paradigm, like, you know, in terms of efficacy research. But you know, maybe it's an okay thing, and maybe it's actually an imperative to be okay with changes to the digital intervention. I think what's really critical is just trying to specify out like what are the core components of that digital intervention, and do those maintain consistency, or is there a change to the digital intervention that's a little bit less you know, less central to the core of the intervention. So, you know, you could think of really minor stuff like changes in the way that buttons are presented that could improve like usability, but even more involved changes than that could be okay. And it just really depends on, you know, how, you know, what exactly are you is your trial specifically designed to test? If it's designed to test the effectiveness of a digital intervention, and that digital intervention changes, then you know, maybe that's an okay thing, because that's the reality of the you know, the technology market. I'm hoping that helps, but I definitely would encourage you to read that article that I pasted.
So another question is, how would you argue the framework is different because of the focus on digital, but for, you know, just evaluating any other kind of behavioral intervention in clinical settings?
Yeah, that's a really good one too. Yeah, what's the value added? I'm happy to take that. I also, Tessa, wanted to step back and see if you want to take that question. You're muted there.
How about you go for it? I'm looking for the link to the pragmatic comparator framework. So I'm going to post that if you want to go ahead and answer this.
Oh, cool. All right. So you work on question 3. I'll work on 2. Yeah, so there's been a long, yeah, that's a really good question. So what's new about this framework? So I'll definitely acknowledge that there's been a long history of studying whether a specific intervention is effective at improving health outcomes, you know, effectiveness trials, that's what they do. There's also a really strong precedent for studying the impact of implementation strategies, which are the efforts to encourage adoption, implementation, and sustainment. And so, you know, those are implementation trials. There's even hybrid trials, you know, a mixture of those two. What we are, you know, I think that the newest part of this framework, what its goal is that we're really trying to encourage researchers to elevate the importance of specifying and evaluating how you choose to deliver the digital intervention in a care setting. So we call that the clinical support services in this framework. It's, you know, that's been called other things as well. But, you know, as we noted, you know, this, you know, the way that you deliver digital interventions in the care setting, that's where we see digital interventions, you know, experiencing the most hiccups is, you know, how does a clinician in the, you know, in their office, you know, what are the steps that they need to take in the office when they first introduce it to a patient, you know, how do you help patients set up these digital interventions, and what do you need to do for follow-up? And so, you know, those could be seen as like a background thing, but what we're saying is actually those are really critical to tackle, because that's where implementation has fallen flat. And so what we're saying is like we should do RCTs on that, you know, and so that's what this framework is arguing, and it provides some approaches for doing that while concurrently also answering questions about implementation strategies and effectiveness.
I can take the next one. So an attendee asks, how applicable is the framework for non-primary care traditional psychiatry clinics? Also, how applicable is the framework to non-SUD disorders like SPMI disorders? I admit I'm not sure what SPMI stands for. Someone jump in if you know, but I do think that this framework can still be applicable to non-primary care settings. Again, it's designed to be flexible and to think about especially the implementation strategies and clinical workflows that are needed. And so in a psychiatry clinic, it's likely that an app or a digital intervention will still require some support from a person. And so that might look different than the support from a primary care doc or someone on the primary care team. But who is that person? Is it support staff? Is it a psychologist, psychiatrist? And so thinking about the workflows, the people involved, the clinicians involved, I think it is still applicable, but I'm open to thoughts. And if this person has any ideas of how this framework they might apply to their setting that they work in, I'd actually be very curious to hear more about that. I don't know if attendees have the option of talking in this webinar. Okay. Email me.
We want to jump to Dennis's question. Dennis Lee asks, how do you differentiate clinical support services from strategies like consumer engagement strategies?
Yeah, that's a good question. So I would have to double check the ERIC framework to see how they, what were the conceptual bounds around consumer engagement strategies to answer that question well. So I'm happy to maybe answer that over email, or Andrea, maybe if you recall what those, what are the bounds of those, I'd be happy to answer that if it's defined.
I think Dennis put a later question. I think maybe this sort of, I think sometimes that chicken or egg question is like, if the digital intervention has components to increase engagement, not necessarily affect the health outcome, is that part of the intervention? Is that part of the service support in the framework?
Yeah, love that question. Yeah, I mean, what I'll say is the way that you think about something, it's really up to the researcher, and you can think of it this framework recommends ways that we think are pretty good ways of specifying things, and that's where we're trying to get it out there. But really, it's up to the researcher. But in this question, which I love, I would say that components integrated into a digital intervention are part of the digital intervention is the way that I would consider it. But that's based on the way that I the types of research questions I ask and seek to answer in trials. But yeah, I'd say that anything built into the app itself is part of it, and I'd consider that the intervention.
Attendee asks, are there digital psychiatry clinics and which institutions have them? I am not sure. I'd have to dig into that a little bit more. I think with the rise of, I don't know, I'm getting ads now for direct to consumer marketing for mental health, and all offered digitally. And I'm just wondering if that would, I'm thinking about how that might apply, but I don't know the answer to this question. Joe, do you know?
Well, there's a couple of, there's a few case studies that have been published. I actually, I wonder if either David or Andrea are aware of the institution names. The case studies are a couple years old, so I'm not sure if they're still operating in that form, but I'd be happy to look them up. They're actually cited in the manuscript that we're working on, Tessa. But Andrea, Dave, are you aware of any digital psychiatry clinics, maybe even at Northwestern or elsewhere?
Well, certainly outside of this country, there are a growing number, and they're just depending on how the healthcare systems are organized, it can vary, but like in Australia or in Denmark, the federal governments fund essentially nonprofits or organizations to deliver digital mental health to either a region or the entire country. I believe some of the provinces in Canada are doing something similar, Alberta. They're integrating digital mental health into the IAPT clinics, the clinics in England, through which a lot of psychotherapy is being done. So digital mental health is being integrated into those clinics. In this country, I think we're a little further behind because, our healthcare system is less unified and organized. But I think at Kaiser, at your place, I think, Kamai is a platform that's now offering, I think, 6 digital health interventions, and they're just contracted out. But last I heard, about 8 months ago, there had been around 200,000 people who had been referred into that program. So Kaiser, I think, has the benefit that it's not a fee for service, so they don't have to worry about billing, so they can implement those things. So that's kind of, it is getting rolled out. I think it's getting rolled out more systematically outside of this country right now until the regulatory and reimbursement processes in this country get established, which is happening.
Yeah, thanks for jumping in there. Let's see, there's one by Kristen for the difference between clinical support services and implementation strategy, those two concepts. I'm still having a little difficulty distinguishing the two, since could one also remove the clinical service and just keep practice facilitation? I'm selfishly asking, since another non-mental health digital intervention that Kristen is designing includes both coaching and practice facilitation. I think I said that right. So how do you distinguish between a clinical support service and an implementation strategy? Yeah, and I think that the example that you're referring to is, Tessa said, one way to figure that out is, can you remove that thing, and can the digital intervention still operate? And so that's actually, your example is really good. Like, a study that's doing practice facilitation or practice coaching, that is to encourage clinicians to it helps the clinicians identify how to maximize the fit of a new intervention into their practice. It helps troubleshoot problems within the clinic that clinics face when integrating a new evidence-based practice in the setting. So it's a really dynamic implementation strategy, with a really strong evidence base. The thing is, with practice facilitation, you can do it for a while and then stop doing it, once the clinics are, doing the intervention, once the intervention is being, delivered smoothly. Of course, you'd want to, continue to do some kind of quality improvement over time, like, to check and say, okay, what's changed? Is this intervention still being delivered smoothly? But just the fact that you can stop doing it means that it's not, part of the clinical intervention that you're delivering, right? The clinical support strategy, or the clinical support service, we are saying that you could change that. Like, you could do it in a different way. Like, you could ask a clinician to, for instance, tell a patient about a digital intervention that's available on a health plan website. And that's, that could be one way of introducing a digital intervention to the patient. They could even email the patient like a couple of weeks later and check to see if they started. If they started, they could email them a couple of weeks later or call them and, check in with them during a visit to see how it's going. And you could also accomplish, the provision of a digital intervention in a different way. So you can change the clinical support service, but what we're saying is that, patients need a way to onboard onto the digital intervention. Health systems need a strategy for supporting patients in the use of the digital intervention. So that's something that can't really go away. If those things go away, then there's really no way of getting that digital intervention to patients. So that's why, we think that these are kind of different concepts. One is kind of inherent to the offering of the digital intervention. The other one really helps encourage clinicians to use that offering.
And then I think the last question, if we have time for, do you think this model would be appropriate for research on the implementation of digital tools to facilitate clinical decision-making for providers, where the clinical outcomes are at the patient level, but the implementation outcomes would be at the provider or the organizational level. I think it would be, and I think there might be some different ways to think about it. That's why that delineation process is really important, because the way that you conceptualize some of these things might vary, but it might be a scenario sort of like the digits trial where you're testing two different things. And so you might have, let's see, you might be testing the digital intervention itself and looking at patient outcomes at the patient level, and you're comparing that to something, as well as you're comparing an implementation strategy or an approach, a clinical support service, and looking at outcomes at the organizational level. And so then you have a couple different approaches you're simultaneously testing. So that's one idea. I don't know, Joe, if you have other thoughts about how that might work.
You know, I love what you said. You know, I'd say like maybe the way to conceptualize that that tool that's facilitating clinical decision making, that would be the digital intervention, and then, you know, the implementation strategies that you put around it to help clinicians, you know, do that thing would be the implementation strategy. Yeah, and there's one more question, but I see we're close to time. Andrea, how do you want to handle that?
You know, it's a big bear, so we can maybe read it and then say, oh, time's up. No, it's whose responsibility is it to create and evaluate clinical support services for digital health? Who should it fall on? Companies, consumers, providers, researchers. I think when we solve that, it'll be terrific. But I would love if you had just a 30-second answer to it.
I think it's, you know, all of us should do it. I mean, the vendor is only going to benefit if their platform is easy to offer in clinical settings. You know, the researchers obviously, you know, should be testing these things, and providers, you know, if it's easier to offer for them, you know, I think it's to their benefit as well. So I think that, you know, a lot of shared learning can be done here.
Thank you. And thank you for a wonderful talk and exciting framework to help us tackle a really, really hard area. So this is really exciting. We appreciate you sharing all this.
Thanks so much for having us here.
Thank you.
Thank you. Thanks for being so engaged. Audience, great questions.
Yeah, definitely. Take care.
Bye. Thank you.
Bye-bye.